in a very similar situation where Myanmar is right now. And I was trying to help. I'm so far away, but we wanted to help. So a group of us got together and conducted some teaching sessions in India. And I kind of modeled my talk today on those teaching sessions. And I'll go fairly fast through all my slides. And then at the end of the session, I hope that there'll be plenty of time for questions. So I'll jump right in. What I was going to talk to you about was very briefly talk about the epidemiology of COVID, what the global situation is, and then talk about the clinical features. And most of my talk will be focused on how to manage patients, whether it's at home or in primary care centers or in hospitals. And then just give you a few things that you can tell family members of patients with COVID. So we are in the world as a whole in the midst of a fourth wave. Cases are rising in many parts of the world. The first wave was primarily in China, and then it came into Europe and the United States. In the first wave, we thought cases were very high, but since then, the number of cases has just grown so much. But if you look at this curve, one thing that stands out is the death rate. So these are all the colored bars are the cases, and then the deaths are this dark line. And you can see that in the first wave, when we didn't really know enough about COVID, how to manage patients, COVID death rates were very, very high compared to the cases. And subsequently, we've learned a lot of lessons, and that I'm hoping I can share with you. And you can see that cases have, each time cases go up, deaths go up, but the death rate has never been disproportionate to the case rates after that initial first wave. So what's going on in Myanmar, just like the rest of the world and many parts of Asia, you had initial rise of cases. You actually had cases fairly late in the game. So in March and April of last year, when many parts of the world were having a problem, Myanmar didn't seem to have a problem. And then you had a wave of cases or a surge of cases between about September, October, November to February. And then I'm not sure if cases just went away or they were not being counted because of the situation in the country. And then since mid to late July, you can see how cases have been rising steeply. Now, these cases are what are called confirmed COVID-19 cases. So these are the ones that have been reported based on positive lab tests. And so currently the case count in the country is estimated to be around 5,500 cases per day. In contrast to that, there are many groups around the world that are doing modeling. And there are two groups in particular, the Imperial College of London and the IHME, or the Institute for Health Metrics and Evaluation. So based on case counts, they model what the actual case counts are, depending on how much testing is available in the country. And these are the current estimates. And those of you who are on the ground there probably can tell me which one is more closer to the truth. It's probably not 5,000 cases per day. It's probably a lot more than that. The Imperial College of London estimates that it's around 110,000 cases, whereas the IHME model estimates that it's more than 300,000 cases per day currently. So like many parts of the world, it's not very clear what the exact case count is, because when you have a lot of cases, testing availability doesn't match that. And in general, I know this was true of India, that we were not able to actually know the actual number of people who were infected because of lack of testing. So let's talk very briefly about the coronavirus. And I'm only explaining this because it has some relevance to what we'll talk about. So the coronavirus, as all of you know, is an mRNA virus. It has very simple genetic structure. And this genetic structure encodes for all the parts of the cell. And one very important part of the coronavirus are these spikes that are on the surface of the virus. These spikes attach to receptors in humans in the upper airway and bind to those receptors, and then they set off the infection. So these spike proteins on the surface of the cell are very, very important to the virus. And the red portion of this genome is what encodes for these spike proteins. And then there are lots of different parts to the virus that are encoded by these other genes within the virus. And like all mRNA virus, so influenza is another mRNA virus. The common cold virus is also an RNA virus. And these RNA viruses tend to be a little bit sloppy. So each time they replicate, there are small mistakes that happen in the genetic code. So every time the virus multiplies, these tiny mistakes happen. When enough of these mistakes add up in the virus, it makes a new variant. And so there have been a lot of mutations because there have been so many infections and so many times the virus has replicated. There have been numerous mutations already in the virus just in the course of the last year and a half. And that has resulted in what are called variants. When these mutations accumulate enough to change the behavior of the virus, that's called a variant. So right now in the world, there are several variants that are called variants of concern because the virus behavior has changed, and that has implications for all of us. So the most important variants that are currently circulating in the world are on this slide. So there's an alpha variant. It was first identified in the UK last year. And what this virus, what has changed with this virus, it has become more transmissible. So there's a 50% increase in how easily the virus passes from one person to another. And there's also an increased risk of hospitalization with this virus. The beta variant was first identified in South Africa in about October of last year. This also has about 50% increased transmission. The gamma virus was first identified in Brazil, and it is causing the majority of cases in Brazil and in many other parts of South America, including Peru and Chile. And this one maybe has slightly increased transmission, but that hasn't been confirmed. And the Delta variant, which is now pretty much the most dominant variant in the world, it's in about 136 different countries. They think it originated in India and caused the deadly second wave in India. This is what is likely in Myanmar now. And this virus has been causing a huge number of cases because compared to the original virus that was responsible for the first wave, this is twice as transmissible. So it's 2 times as likely to cause infections in people. It increases the risk of hospitalization by, we think, something like 50%. And it has a shorter incubation period. So once you're exposed, people tend to get symptoms within 2 to 4 days versus 5 to 10 days that was happening with the wild type virus and with the alpha variant. In addition, all of these variants seen and also cause have reduced susceptibility to some of the monoclonal antibodies, which we'll talk about at a later time. So this Delta variant, again, I just want to highlight some more things about how transmissible this is. On the x-axis is how easily the virus transmits from one person to another. And on the y-axis is see here that things like Ebola are very deadly, but not as transmissible as some other infections. And 2002 was very, very deadly, but did not cause, but was not as easily transmissible. In contrast, almost as transmissible as chickenpox, but fortunately, it doesn't cause as much death as some of these other infections like polio and Ebola.
ကိုဗစ်အကြောင်းဒါနဲ့တွေ့နေတာတော့
So how is this virus transmitted? So we have learned that the most common way of transmission is the droplet mode. Whenever someone who's infected with the virus coughs, sneezes, speaks, or especially sings, the virus is expelled into the air, other people around them breathe it in, and that sets off the infection in the exposed person. This means that just wearing a regular mask can protect people. In rare instances, so in the hospital when or in a very crowded area, airborne transmission may play a role. So for droplet, you typically need to be within 6 feet of the individual. When the virus is airborne, the virus can travel further. And so in a very crowded room with a lot of people, there can be airborne transmission where even if you're not within 6 feet of the infected person, you can acquire the infection. When we first started thinking about COVID back in 2020, there was a lot of concern about surfaces, cleaning surfaces, keeping things clean around the patient in order to prevent transmission. And this turns out not to be a significant way that infection is transmitted. Certainly if the person coughs and right away you touch the surface, you can acquire infection on your hands. And if you touch your nose or mouth, there's some small risk of transmission, but this is not the major way that infection is transmitted. So one thing that is very important is that transmission can happen even when the person doesn't have any signs of infection. So as we'll talk about later, about 30% of people who are exposed to COVID and get a COVID infection may not have any symptoms at all. And these people, however, can transmit to other people. And that's why masking of everyone when there's a large outbreak in the community is so very important. So again, how the infection is transmitted: when an infected person coughs, sneezes, these droplets travel. The droplets that are expelled from an infected person are kind of heavy, so they don't travel very far, most likely only about 1 meter or 3 feet, and then they fall to surfaces. In crowded spaces, these droplet nuclei can travel a little bit and you can have some airborne transmission, but this droplet within a few feet of the infected individual is likely the most important mode of transmission. So then how do healthcare workers protect themselves when they're taking care of patients? So this is what is recommended as PPE. You need to wear a mask. You need to wear some sort of eye protection. It can be goggles, it can be a face shield. Those are very, very important. The gown and gloves are not as important. If you're having trouble finding these, washing your hands immediately after contact with the patient can substitute for gloves. And just any type of covering over your clothes can also help instead of a medical gown. But the most important pieces of PPE that you need are this mask and some sort of eye protection. The reason the eye protection is important is that when a patient coughs, these particles can contact the mucous membranes of the eyes. And these mucous membranes actually have a lot of the receptors for the COVID virus. So when they bind to those receptors, you can get an infection. So how does COVID present? COVID is primarily a respiratory infection. So you have a lot of signs and symptoms related to the lungs. The usual incubation period is roughly 4 to 5 days. With the Delta variant, we're seeing that has decreased a little bit to maybe 3 to 4 days. But overall, 4 to 5 days is probably the time that most people have symptoms after exposure. The symptoms initially are very non-specific. You can have fever, chills, you can feel tired, body aches, headaches, sore throat. Then patients go on to develop a cough. One thing that is unique to COVID is that if it's present, it's very, very characteristic of this infection is loss of taste or smell. And this happens, sometimes when you have a cold, you can feel like you can't taste things, things don't smell as good, but that's usually in association with a stuffy nose. With COVID, you can have the loss of taste or smell even without a stuffy nose. And that is one of the things that, especially when you have a lot of cases in the community, that's almost always due to COVID. Some patients have nausea or vomiting and diarrhea, especially with the Delta wave in India. A lot of patients presented with vomiting and diarrhea. And then if this progresses, patients can develop shortness of breath as there's more and more lung involvement. So there's a spectrum in patients with COVID. Not everybody gets very sick. And so the illness ranges from completely asymptomatic to very sick patients. And fortunately, based on the data we have from the cases in China and in the US, we now know that almost 30% of people will have no symptoms at all. Of those that have symptoms, the majority will have very mild disease and they can stay at home and be taken care of at home without needing any medical care. Roughly 15 to 20% of patients will need oxygen, whether that's done at home or in the hospital. So still with a lot of cases, this is good news that only a small proportion actually need advanced care. Not everyone needs care. What about mortality? Overall, mortality for COVID tends to be low, between 0.15 to 1%. However, in patients who are hospitalized, who are sick enough to go to the hospital, the mortality in these patients is roughly 5 to 10%, depending on on what sort of care they're able to access. So when you have a patient with COVID, there are some things that can help predict who will go on, which patients will be in that 80% who don't need any additional care and who might progress to severe illness. So some of the risk factors that are bad risks can predict the patient getting more ill would be one, age. So especially age over 80, but age starting at around 50 is when the risk for hospitalization increases. And then those with certain comorbidities. And amongst those, probably the two most important ones are obesity and diabetes. These are very, at least in the US, obesity is very, very common. And then in Southeast Asia, diabetes is very, very common. And these two, unfortunately, are poor factors for progression to more severe disease. Some of these other things also, patients who have cancer, patients who have any kind of chronic kidney disease, chronic heart disease, chronic lung disease have increased risk. Smokers, those who've had organ transplants. And then finally, male gender also predicts progression to more severe disease than women. And the death rate is also higher in men than women. So to understand how to manage COVID, I think it's important to think about all the different phases of the disease. So the first thing that happens is patients are exposed to the disease and the virus multiplies in this individual. That's the early stage of the disease. During this phase, the viral load is actually very high in the upper airways, and that is when the patient is most infectious, when this viral load is very high. As over the course of the next few days, the viral load actually comes down as the body's immune response takes care of eliminating the virus. And it's during this phase, as the viral load is actually coming down, that you have what's called the pulmonary phase. So at this point, if you did a chest X-ray or if you did a CT scan, almost all patients will have a slightly abnormal chest X-ray, which can then progress to more severe disease. And this is when they have the cough, they may be short of breath, and they may have hypoxia or low oxygen levels. During this phase, some patients just recover, clear their virus, and do fine. In a small number of patients, so that roughly 15 to 20% that we talked about that need hospitalization, the body has an acute inflammatory response. The virus is coming down because the body's inflammation is reducing the viral load, but the body's immune response itself is causing additional lung damage. So during this phase, you can have worsening pulmonary infiltrates, you can have progression to ARDS, you can have the need for mechanical ventilation. So this then goes into the hyperinflammatory phase where the patients can be very, very sick and have ARDS, heart failure, shock, and need ICU care. So during the early phase, there is a lot of virus. Patients are highly infectious, but they don't have a lot of symptoms. During the second phase, they start having pulmonary symptoms. Many people just stop there. Small number of people go on to have the hyperinflammatory space, and that's where you have the very, very sick patients. So how do you take care of these patients? So I'm going to give you a very simple approach to affects pretty much every body system. It causes inflammation in multiple different organs. But the most significant thing is the lungs. So when you have a patient, so first of all, when a patient presents with a fever, headache, the possibility of COVID, there are lots of other things that can be the problem, but if they've been exposed to COVID, then almost certainly in the current COVID. So ideally, these patients should get tested with a PCR test to see whether or not they have COVID. Now, that is not always possible. Assume they have COVID, and then you assess them to see how severe the COVID is. So the basic thing that you use to assess severity of illness would be looking at the patient and their respiratory rate. Comfortable, if they have no obvious signs of difficulty breathing, and if their oxygen saturations are good, that is more than 94%, then you can tell the patient that they can stay home and continue to watch for symptoms. In order to limit transmission to others, it's very important that they wear a mask even around their family members. These patients should be told that if they can have access to an oxygen saturation meter, they can check their oxygen saturations 3 to 4 times per day. The only medications they need are fever-reducing medications, paracetamol, acetaminophen, things that reduce fever. If these patients have access to a steroid inhaler, they can use the steroid inhaler, but it's not an important factor, and I'll talk about this some more in a little bit of detail. So these patients will, as I said, 80% of them will do fine, won't need anything further, they will recover completely. If the patient has some signs of either difficulty breathing, so their respiratory rate is increased, or if you have an oxygen pulse oximeter and are able to check their oxygen saturation, then if the oxygen saturation is less than 94%, you should admit them to the hospital if possible. Now, this may not always be possible, especially when you're having a lot of cases and there are no hospital beds, or there are other problems that keep you from admitting the patient. So in these patients, what can you do? So something that can be very helpful is proning the patient, having the patient lie on their stomach instead of their back. And I'll talk about why that's important. In COVID, there, as I said, it affects every organ system. And one of the things it affects is the endothelial system, so the lining of the blood vessels. And patients who are moderately sick with COVID tend to have blood clots in the veins and in the arteries. So if you're able to access an anticoagulant, then that is it's important that you start it at this time. So I've listed an oral anticoagulant, apixaban. I know this is available in Myanmar, and the dose is 2.5 milligrams twice a day. It can be done at home because it's oral. And if this is not available, then some other alternatives to it are listed at the bottom. So rivaroxaban or Xarelto, 10 milligrams once a day. If that is not available, but you have access to low molecular weight heparin, you can use enoxaparin. 0.5 milligrams is a sub-Q injection once a day. And if that's not available, then unfractionated heparin can also be used sub-Q 3 times a day. If the oxygen levels are dropping further to less than 92, then these patients definitely need oxygen. And you can start oxygen. You start at the lowest level and keep checking their saturations and increase the oxygen as needed to keep the saturations greater than 92%. I know that oxygen shortages happen when cases increase, and so you have to use oxygen very wisely. And it's fine to keep the oxygen saturation just around 92%. It's not necessary to get it up higher than that in order to conserve, so that conserves oxygen and makes your oxygen last longer. The other medication that's really, really important is steroids. So as I told you earlier, this is the phase when they have worsening lung symptoms. This is when there's a lot of inflammation going on, and that's what's driving the hypoxia. So dexamethasone in this stage can be life-saving. The standard dose that we use is 6 milligrams once a day. You can give it for up to 10 days or until the hypoxia improves. So if the patient is feeling better in 2 or 3 days, you can stop the dexamethasone, but the maximum that you should use it for is 10 days. If dexamethasone we use dexamethasone because it's very convenient, it's only once a day. If dexamethasone is not available, you can use this equivalent dose in prednisone or prednisolone, which is 20 milligrams twice a day, hydrocortisone 40 milligrams 4 times a day, or methylprednisolone 16 milligrams twice a day. And you'll have access to these slides so you can refer back to this. If the patient is worse than that, so despite giving them supplemental oxygen, their saturations keep dropping or the respiratory rate goes up to more than 30, then that's when they definitely need admission to the hospital and to the ICU if possible. If you're not able to admit them, you can still try to manage them at home. Keep checking oxygen saturations. These patients need to have it checked more frequently so that you adjust their oxygenation. If you have access to non-invasive ventilation, CPAP or BiPAP machines, this can be started at this point. Again, the proning can be very important. You can do some blood work if they're in the hospital, and what the tests that we generally do are a CBC, the white count, a CRP to assess how much inflammation they have, and a D-dimer, again, to assess whether they have blood clots in the lungs that are causing the severe hypoxia. And then these patients, again, you will continue the apixaban or start it if you're seeing the patient for the first time now, and the dexamethasone. So if these patients are in a hospital setting and they continue to worsen, and they have they're younger and they don't have diabetes, we don't recommend this in general. But if the patient is getting worse and you don't have any other options, one thing you can try is increase the dexamethasone to 20 milligrams once a day for 5 days, and then cut it back down to 10 milligrams a day for 5 days. This is also at the point where you may consider using a medication called tocilizumab, which is probably not readily available. And so the higher dose of dexamethasone is the alternative. In patients who are older and have diabetes, we don't recommend going to the higher dose of dexamethasone because the diabetes tends to worsen and they don't have good outcomes. So in all of these patients, one other thing that I want to mention is that COVID itself causes some inflammation of the pancreas. So it can give patients who've not previously had diabetes high blood sugars. So if possible, you should be checking blood sugars at least once a day in all patients and who are on steroids. So the dexamethasone, the Delta variant itself gives you high blood sugars. And then on top of that, when you have dexamethasone, that also increases blood sugar. So it's very important that you check blood sugars at the time you start the steroids and then daily if possible. So this is sort of broad outline of how you manage COVID. Now, in some parts of your country, you may not have access to a pulse oximeter. So what do you do in that instance? You can try to assess the patient just based on how comfortable they are. So I think about mild disease as patients can walk comfortably around the room when you're assessing them, and they can talk to you in full sentences. They don't have any difficulty with talking. The moderately ill patients are those where they can talk to you, but they have difficulty with walking. So you ask them to walk around the room for 1 or 2 minutes, they start getting short of breath. That is the moderate category. And then the severe category is those patients who have difficulty at baseline talking. They're weak, they're not able to walk because they become very short of breath with walking, and they're not able to talk in full sentences because they have shortness of breath. So that's mild, moderate, and severe. So I told you that I would talk about this inhaler. So there was one small study that talked about, that looked at this role of steroid inhalers, and patients were randomized to usual care or the inhaler. And the people who got the inhaler, it reduced the time to recovery by 3 days. It also reduces the cough in these patients, but it does not really decrease very much the risk of dying or the risk of progression. So this is not an important part of the treatment. If it's available, then it's fine to use, but don't worry about it if you can't find the medication. So I wanted to spend a little bit more time talking about oxygen, because oxygen and steroids are probably the two medications that are life-saving in COVID. So there are many different ways you can administer oxygen, including at home. The usual way that oxygen is administered is nasal cannula, and this can provide oxygen levels of up to 6 liters per minute. And if you place a surgical mask over the nasal cannula, so the patient gets the oxygen cannula and then you put a surgical mask on top of it, that actually conserves the oxygen. It's an easy way to make your oxygen last longer. So the oxygen cylinders have this gauge on them that tells you how much oxygen is left in the cylinder. And here I've listed here some ways that, depending on the size of the oxygen cylinder and the flow rate that you're using, you can figure out how much time you have left on in your with oxygen available from that cylinder. Some patients need more reservoir or mask, you can actually provide up to 15 liters per minute. This is, again, going to use up your oxygen very quickly, isn't sustainable for a long period of time. The other alternative, if you can access it, is an oxygen concentrator. The oxygen concentrator converts water into oxygen and hydrogen and supplies a constant supply of oxygen. These machines can give certain types of machines can give you up to 10 liters per minute. Provided you have a source of electricity or a generator, these can be used very short supply. And unfortunately, in India, we had a lot of deaths because of just lack of oxygen. Securing oxygen is important. Again, these were things that happened in India during the second wave. So when you're giving patients oxygen, you first start out at a low rate, wait 5 minutes and recheck the oxygen levels, or assess the patient to see if they're becoming more comfortable, and then keep increasing the oxygen by 1 liter per minute. All of you know that oxygen oxygen itself is not flammable, but it causes everything around it. It feeds a fire and can make it and be a fire hazard. So no smoking around the oxygen cylinders. If an oxygen cylinder is dropped, that can also, when you open it, you have to be very careful. So handle the oxygen cylinders carefully. And again, this will be available to you. And there's also this website called India COVID SOS, where all of these resources are posted. What about steroids? I've listed a lot of data that summarizes the literature to date on the role of steroids. The bottom line is that steroids are life-saving when used in the right situation. So steroids are only indicated in patients who have hypoxia. In patients without hypoxia, if you use steroids, there's actually a trend towards higher mortality. So use it in anybody whose oxygen saturation is low. Use it for a maximum of 10 days, and you can actually stop at less than 10 days if the hypoxia has recovered. And do not use it in patients who do not need oxygen. Proning. So I wanted to take a few minutes to talk about this, because this is something that can be very simple to do, but can also be life-saving. So when a person is lying flat on their back, most of the air that they breathe in goes to the ventral portion of the lung, so the part that's towards the front of the chest. And these alveoli get hyperinflated. The alveoli that are at the bottom of the lungs collapse. So all the air is going here. But when you think about the blood flow, all the blood flow is going to the bottom part of the lung. So there is what's called a VQ mismatch. So when you're breathing normally, when your oxygen levels are good, this mismatch doesn't make much of a difference. But when you already have inflammation in your lungs, this mismatch makes a big difference. So what happens when the patient turns over? When the patient turns over, the lungs are inflated. All the alveoli in the lungs, both the posterior and the anterior alveoli, get inflated about the same. The blood flow now comes to this part, and the VQ mismatch is no longer present. So this by itself, even in the absence of oxygen, can increase your blood oxygen levels. So this is very simple to do and can be life-saving. So how do you do it? So we recommend that when patients are diagnosed with COVID, if they start having hypoxia, that you tell them not to lie on their back, instead to lie on their stomach. And you can put a pillow under the chest and a pillow under the knees. And this position should be held for at least 30 minutes and up to 2 hours if possible. Now, this is not always comfortable for patients, so the other alternatives would be to lie on their right side or their left side. Even that helps. It's better than lying on their stomach. So in a patient who's fully awake and comfortable doing this, we recommend lying on the belly and then 30 minutes to 2 hours later, lying on their right side, and then sitting up in a semi-recumbent position, and then lying on the left side. So turning between these positions and avoiding lying flat on the back. And this seems very, very simple, and it is very simple in a patient who's awake. It can also be done in a hospitalized patient. They may need some assistance to move from one position to another, but this can actually be life-saving. One thing that I did not address at all in that algorithm that I showed is remdesivir. Remdesivir is a antiviral medication that was considered to be essential in the treatment of COVID. Got a lot of hype and caused a lot of problems in India because it wasn't available. People were desperate to get it, and this caused more problems than good during India's second wave. So this is, and it's also very expensive. But the bottom line is that it really has not been shown to make any difference in mortality in patients with COVID. And we do not recommend using it routinely. In a very small subset of patients who present early in the course of their illness, if you give it to them, it can reduce the number of days of hospitalization. But since it makes no difference to overall mortality, it really is not necessary, and you should tell your patients not to try to find it because the benefit is so marginal. So in summary, what are the things that are life-saving in COVID? What are essential for treatment of patients? Oxygen, steroids, and proning. What can be useful would be adenoside. Remdesivir, really marginal benefit. The other thing that we haven't talked about is monoclonal antibodies, and we can do that at a later time. This is in patients who have mild illness to prevent progression. Things that are not useful. I just wanted to take a couple of minutes to talk about this because a lot of people take these things. Vitamins, taking higher doses of vitamins, vitamin D, vitamin A does not make any difference to COVID. Zinc supplementation does not make any difference. Plasma was also something that was searched for. People were desperate to get plasma. This just is not helpful. And things that are actually harmful, I put steroids as life-saving, but steroids can be harmful if they're used at higher doses than are necessary, and also harmful if they're used early in the course of illness when patients don't have hypoxia. Patients with COVID almost never have bacterial infections in the early part of the disease, so giving empiric antibiotics is not necessary and can actually be harmful. Other medications that have had a lot of press include ivermectin, hydroxychloroquine. These have no role. They don't benefit the patient at all and can be harmful. Antiviral drugs like lopinavir, ritonavir, favipiravir also have not been shown to be helpful. And then immunomodulators like itolizumab, bevacizumab, these were all drugs that people were desperately searching for during India's second wave. Again, they also did not have any benefit or need any help. This is a summary of taking care of how to take care of patients at home with COVID. So if you have most patients with COVID can stay home. If they have access to an oxygen a pulse oximeter, they should check their oxygen levels. They should wear a mask at home, even around their family members, because not everyone in the family might have been exposed. If you can open windows, that's helpful to improve ventilation. Stay hydrated, take any fever reducing medications. If the oxygen level is 92 to 94%, you can still stay home, but you may want to start proning at home. And then when oxygen is less than 92 to 94%, you will need supplemental oxygen and also steroids. So the one point I wanted to make is that the Delta variant is much more transmissible than previous versions of COVID. So this was the original version. So when one person got infected, they spread it to roughly 2 people. With the Delta variant, if one person is infected, they can spread to 5 to 8 people. And in our experience, if one person in the family has COVID, almost everyone else in that household will get COVID. So what advice do you give family members when one person in the house is infected? Say that one of the things that can help to limit transmission is assign one family member to take care of that patient rather than everybody helping that patient. So if the mother is sick, say only one daughter takes care of the mother, everyone else stays away from the mother so that they protect themselves. Anybody who's taking care of the patient should wear a mask and preferably eye protection also. These people should wash their hands after they take care of the patient. Everybody else in the household, if they were exposed to the patient, should stay home and not allow guests to come into the house. They should not go to the market, etc. Because they're likely to they've probably been exposed, and you shouldn't allow the virus to transmit further. Ventilate the room as much as possible, keeping windows open. And everybody else in the household should monitor themselves for COVID for 14 days. The maximum incubation period is 14 days. So if you don't have symptoms at the end of 14 days, you can go back to your usual routine. I created this website during the height of the COVID crisis in India. It's called covidindiatreatment.com, and it has many of the things that I talked about here. You can also submit questions on COVID through this website that I try to answer along with the colleagues listed here. So that is all I have.
Thank you so much, Dr. Priya. The presentation was clear, concise, and great. So
So I have some questions in the chat, and I'm going to try to answer them. A recommendation for dexamethasone, somebody asked a question about why can't you give IV? You can certainly give IV. The dosing for all IV. If the patient can take oral is cheaper and less risk of other types of infections with oral than with IV. Raising their hand. Do you want to ask a question?
Yes, Dr. Priya, thanks so much for your comprehensive and very informative presentation. So we have learned a lot. So your slide is some antibiotics are harmful, like azithromycin and doxy. So in the stage 2 patient, when if the cytokine storm was started, if the patient is suffering of the pneumonia, and do we need to provide the antibiotic therapy like azithromycin and other broad spectrum antibiotic or not? So this is my first question. Okay, and my second question is, you know that in our country, the D-dimer are very popular and advanced. And what I learned in the Google and some study, the patient who recovery from COVID, the mandatory tests are some mandatory tests need to do, like chest X-ray and other blood glucose and antibody tests, but it not include the D-dimer for the recovery of the mild and moderate COVID patient. So, my question is, the D-dimer is a mandatory for patient for the recovery of the patient who are suffering of the mild to moderate. So, thank
Yeah.
you.
Yeah, so antibiotics, first, antibiotics in COVID itself, in contrast to other viral infections, even influenza, sometimes patients come with bacterial pneumonia in addition to influenza. With COVID, there is really no risk of community-acquired pneumonia along with COVID, so you don't need to give antibiotics. In a hospitalized patients with COVID, after day 10 or so, if they are at risk for getting a hospital-acquired pneumonia. So if the patient starts having a new fever, starts having a cough that's productive of sputum, and chest X-ray shows a lobar pneumonia, in that situation, you may need to give antibiotics, but early on, you do not need to give antibiotics, even in the ICU setting. When they have the cytokine storm, they don't have bacterial infection at the same time. The second question was about D-dimer. So in our experience, if the patient doesn't have risk of bleeding, we just give anticoagulation with either an oral agent or with heparin, and we don't routinely check D-dimers anymore. We were doing that. So you don't need to check D-dimers to assess recovery either. If the patient has been improving and then starts suddenly becoming more hypoxic, the D-dimer can be helpful to decide if they have a pulmonary embolus. So, and in that case, D-dimer levels are usually very high. So over 3,000, they're in the 5,000, 10,000 range. In that case, then you may move from the prophylactic anticoagulation to full anticoagulation. So the D-dimer is helpful in that situation, but it's not helpful for routine monitoring of patients. The other thing you noticed was I didn't really talk about lab tests much. And if you go to a tertiary care hospital in the US, they do a lot of lab work, but it's not particularly helpful. The one lab test that is very helpful is the blood glucose. So that is really the test that's most important. I don't think any other test is needed routinely, but depending on the patient, if they have chronic kidney disease, you may want to check electrolytes. If the patient has been vomiting, etc., you may want to check creatinine and electrolytes.
Okay, thank you very much.
Yeah, so I'm going to try to address some of the questions in the chat. One was, in moderate stage treatment, dexamethasone for how many days? So the usual dexamethasone is maximum of 10 days or until hypoxia resolves, whichever is sooner. So you can give 3 days, 4 days. If the oxygen level comes back to normal, you can stop the dexamethasone at that time. And then, is metformin contraindicated to manage diabetes while the patient is having COVID? The answer is no. If the patient already has diabetes and is on metformin, you can continue that same medication. You should check the sugars, and some of these patients who are already diabetic may need something in addition to the metformin. So until the COVID resolves, they may need small doses of insulin to control the blood sugars, but you do not need to stop the metformin. Same thing with hypertension. You don't need to stop their routine medications, including ACE inhibitors, when they have COVID.
Are there any more questions from the participants? And also, we put, we note down, we wrote a link to fill in your email and or if you have any comments for us, and you can use the link to enter your email, and we will send you the PowerPoint to your emails. Thank you.
And there's one more question about diarrhea. What medications can you use? Usually in COVID, the diarrhea is not very severe, so just giving fluids, allowing them to rehydrate is enough. If you need anything, then the medication that we would recommend would be Imodium, nothing more than that. And Win Lei has a question. Do you want to ask your question?
Yes, thank you for your very informative talk, madam. I'd like to ask, can every patient with less than SpO2 that DOAC agent? And if
Sorry, I didn't hear that. Can you repeat the question?
can every patient with less than SpO2 that DOAC agent? Steroid as an oral anticoagulant.
Oh, yes. So, yes. Because the hypoxia is a marker for more severe disease, and more severe disease is associated with the higher risk for blood clots. We do give anticoagulation to everybody who is admitted to the hospital, or in the second wave in India, because hospital beds were so tight, anybody who needed oxygen, we were giving anticoagulants to. And then I have another question in the chat, which is, can we use N-acetylcysteine IV in moderate or severe case for respiratory support? We have not used that, and even in ARDS due to other reasons, the use is sort of not quite supported by the literature, so we don't use the N-acetylcysteine. So one more question in the chat. What is the duration of stage 1? So typically stage 1 so the early disease where you have mild symptoms in COVID during the early part of the pandemic was about 7 days. So most patients started out with symptoms, they had mild symptoms, and then by day 7, they progressed or they improved. With Delta, it appears that the progression of the disease is faster, so patients are deteriorating more quickly. So they start having symptoms, and by 4 or 5, they start having hypoxia if they're going to progress. So the stage 1 is shorter with the Delta variant than we saw in the first part of the pandemic.
I think we will have one last question in the chat, and we will probably close it for the interest of time. Thank you.
Okay. So I will try to answer the questions as fast as I can. Some patients complain about hiccups. Unfortunately, there are no good medications for hiccups, so I don't have a good answer to that. I haven't seen that very often with COVID, but we have patients with other diaphragmatic irritation, and unfortunately, no medication works really well. Any role of clopidogrel if apixaban is not available? It has not been studied, and it is an antiplatelet agent, and it's also expensive. So I would recommend staying away from clopidogrel. Really, apixaban, heparin are the ones that, or rivaroxaban are the ones that definitely work. If you can't access those, the next best thing is for patients to walk regularly. That reduces the risk, at least, of the venous blood clots. And if they can do that, then rather than clopidogrel, aspirin would be the cheaper and more reasonable alternative. So the next question too was the antiplatelet aggregators. I think amongst the antiplatelet agents, probably aspirin is the one with the biggest track record. So that would be the one that's preferred over the newer ones. And then one last question was, how many days do you need to continue isolation? 14 days is the recommended with the Delta variant, because it's if there is a problem with 14 days and at least 10 days. especially after if someone's been exposed, the quarantine should be at least 10 days, although 14 days is ideal.
So I think we're okay for now. Oh, and one last question just came in. Dr. Priya, would you have time for one last question?
Yeah,
Thank
so
you.
the self-isolation also same thing, minimum 10 days, ideally 14 days.
Thank you very much, Dr. Priya. Thanks for giving us time out of your busy schedule to make it to this seminar. We appreciate it. And also thanks for answering all the questions.
You're welcome. You're welcome.
Sani, do you want to say anything from your side?
Thank you so much, Dr. Priya and Sayatat. ဆရာတို့ကျွန်တော်တို့ကျေးဇူးတင်တယ်ကျွန်တော်တို့ဒီ Google Form မှာကျွန်တော်တို့ဖြည့်ပေးလို့ရတယ်တကယ်လို့ Google Form ကဒီပေါ့နော် VPN ကြောင့် access မဖြစ်ဘူးဆိုရင်ကျွန်တော်တို့ဒီ MMOC page မှာ message ကနေပြီးတော့ email ပို့ထားလို့ရတယ်ကျွန်တော်တို့ခုဒီ live ကျွန်တော်တို့ဒီ lecture ကိုကျွန်တော်တို့ဒီ YouTube မှာကောဒီ Facebook မှာကောကျွန်တော်တို့ဒီ live ကျွန်တော်တို့တင်ထားတာဖြစ်တဲ့အတွက်ပြန်ပြီးတော့နားထောင်လို့ရတယ်နောက်ပိုင်းကျွန်တော်တို့ဒီဒေါက်တာ Priya နဲ့နောက်ပိုင်းဒီလိုမျိုး lecture တွေရှိရင်ကျွန်တော်တို့ MMOC ကနေကြေညာပေးပါမယ်ဟုတ်ဆရာရပါပြီဆရာ Thank you so much
Thank you everyone Bye
Thank you.
Thank you bye
Thanks so much. Thank you so much. Thank
Bye-bye.
you very much.
Bye bye.
Bye-bye.